And I'd like to welcome everybody to today's webinar, Addressing Adverse Childhood Experiences, also known as ACEs, and Health Disparities in Marginalized Communities. This will be a panel discussion. Our panelists for today are Naomi Shapiro, Elena Josway, and Cornell Jenkins. And I'd like to remind you guys that this presentation is being interpreted into Spanish. So if you want to listen to this presentation in Spanish, at the bottom of your screen, there's an icon that looks like a globe. Simply click on that icon and select Spanish to be able to listen in Spanish. Likewise, we also have the slides interpreted into Spanish. So if you go to the very top of your screen, there's a tab that says View Options. Click on the View Options tab, and you can select Diapositivas en Español for Spanish or Pam Secada for the English slides. And with that, I'm going to go ahead and let Pam take it away. Thank everyone for joining us.
Good morning, everyone. Good morning from California, and welcome to today's webinar, Addressing Adverse Childhood Experiences and Health Disparities in Marginalized Communities, a panel discussion. My name is Pamela Secada Sales, and along with my colleague, Alma Galvan, we will be the moderators for today's discussion. So this panel, like I mentioned, this discussion is brought to you by Migrant Clinicians Network. MCN is a national nonprofit with extensive experience providing timely, practical solutions at the intersection of vulnerability, migration, and equity, where migration is never an impediment to well-being. Our work consists of many different components. We do resource development, education, research through our IRB, worker health and safety, support for provider well-being, and many more. So let's take a quick look at our agenda for today. Before we begin, I'll do a quick introduction of our panelists. Then we'll do an introduction to ACEs to give you some context. Then each of our panelists will then share their insights and experiences and research related to ACEs. And then after the presentations, we'll engage in a moderated discussion. And
Can I interrupt you really quickly, Pam?
Yes.
When you advance your slides, can you just say next slide so that Kari can keep up with you?
Okay, no problem.
Yes. Thank you.
And then we'll end with audience Q&A. And here we'll ask if you have any questions specific to one of the panelists, if you can please make sure you add the panelist's name on the question so that we can properly and accurately give the panelist the question. Next slide. So we're joined today by our panelist, Elena Josway, Program Director of Futures Without Violence, Naomi Shapiro, Professor Emeritus of Family Health Care Nursing at University of California, San Francisco, and Cornell Jenkins, VP of Programs, Impact, and Evaluation at the Catalyst Center. Next slide. So what are adverse childhood experiences? ACEs are highly stressful and potentially traumatic events or situations that can occur before the age of 18. These experiences can have a negative impact on our physical and mental health, and it can affect the way we feel, we behave, and the way that we view the world. Next slide. The ACE study is one of the largest studies ever conducted to assess the association between childhood maltreatment and later life well-being. The study was a collaboration between the Center for Disease Control and Kaiser Permanente. And each study participant was asked to look back on their childhood experiences that they had prior to the age of 18. And what they found was that the more ACEs people were exposed to, the greater the likelihood for negative health outcomes later on in life. And here's what we like to emphasize, that ACEs is not a life sentence, and it does not guarantee negative outcomes. Like I said, it increases the likelihood of them. Next slide, please. So the ACE study identified 3 different categories of adverse experiences: physical, emotional, and sexual abuse, physical and emotional neglect, and household dysfunction such as parental substance abuse, mental illness, domestic violence, separation, divorce, and incarceration. Studies indicate that a significant portion of our population has experienced at least one adverse childhood experience. Next slide. So ACEs impacts the physical, psychological, and behavioral and societal consequences. And it impacts the child's development, the relationship with others, and increases the risk of engaging in health harming behaviors in adulthood. Next slide. So here's where I'll go ahead and hand it over to Elena Josways from Futures Without Violence.
Thanks, Pam. Can everyone hear me okay?
Yes.
Great, thanks. So like Pam mentioned, my name is Elena Josway. I work at Futures Without Violence. We are a national health and social justice nonprofit, and we build programs, public action campaigns, develop trainings, all designed to prevent and end domestic violence and trauma. I'm on our health team, and our health team does a lot of work with healthcare providers, with community health centers, all about the health impacts of domestic violence and trauma. And you can find more about us and our resources on our website listed on the slide. Next slide. So Futures Without Violence has done a lot of work, like I mentioned, with healthcare providers about addressing the long-term physical, mental, and behavioral risks associated with ACEs. And we know that healthcare providers do have such a unique opportunity to help prevent and respond to ACEs in clinical settings. A few years ago, Futures developed a series of what they called core and supplemental trainings through the California's ACEs Aware initiative. And the trainings enable Medi-Cal providers to earn what they call here in California an ACEs Aware certification. The training is not limited to California providers. So anyone can access the trainings on our website. There's a recorded training and the PowerPoint slides all available. The training comes in a 3-part series and discusses issues such as ACEs and toxic stress, equity and trauma-informed practices in healthcare settings, and increasing staff capacity related to trauma-informed care and ACEs. So after I'm finished talking, I'll drop the links in the chat so you can check out the longer recordings to those trainings that are up on our website. In addition to that work, Futures has, in 2022, we launched a pilot project called Project Messes. And I'm so excited that our pilot project partners are here today in the house. We've been working with Migrant Clinicians Network and the RAND Corporation as our evaluation partners on the project. And our other partners are Líderes Campesinas, and I saw Ana Solorio in the comments. I know she's here too, from Líderes Campesinas and also Alianza Nacional de Campesinas. The project is about addressing the health impact of ACEs and toxic stress in farm worker communities. And the goal of the project is to collaborate with farm worker leaders and community health centers to address the impact of ACEs and toxic stress in the community. We're doing that through developing ACEs education in the community. We're doing that through screening and universal education in clinic settings. And we're doing that through conversations we're facilitating between providers and patients on resilience and the impact of ACEs on health. Part of, I think, what has been really important part of the conversation for that project is to recognize that there are structural factors that impact farm worker ACEs, access to prevention and response strategies. So in addition to ACEs, exposure to other adversities such as poverty, family separation through immigration structures, racism, discrimination, housing, and food insecurity, these are all associated with health risks and are also believed to be risk factors for toxic stress and impact the ability of someone to have access to ACEs prevention and response strategies. In California, there was a health study conducted in 2021, farm worker communities, where 48.6% of the farm worker surveyed were without health insurance in those previous 12 months. And according to the American Community Survey, in 2019, California farm worker median wages were $21,915. Two-thirds of farm workers expressed the highest level of fear of family separation due to fears around deportation. So addressing structural factors like these that can impact someone's access to care, can impact someone's health, is also critical to the ways in which we respond to ACEs. And we're so lucky to have partners in this project that, like Líderes Campesinas, like Alianza, like MCN, who are thinking about these structural factors as well as we think through strategies to address ACEs. In the pilot project, farm worker leaders have trained members of their own community about ACEs and toxic stress, and then have asked the community what they would like to see in terms of a community health center response to ACEs. With that information, and together with our partners and those leaders, we've trained staff at different community health centers here in California that are serving farm worker communities. Those clinics are now implementing an adapted approach to addressing ACEs through universal education, which I'll talk about in a little bit, through screening, and also they're partnering together too and having conversations about ways to better address access to care issues for farm workers in the community. Like I mentioned, we're testing these strategies and evaluating this work, and hopefully in the next several months to year, we'll have some recommendations that we'll be able to share with health centers. Uh, um, and we're really, like I mentioned before, we're so lucky to work with evaluation partners at Migrant Clinicians Network and at the RAND Corporation, who are helping us look at the impact of these strategies. So like I mentioned, Futures offers trainings that we've done to community health centers around ACEs, around intimate partner violence. And we offer trainings on what we call universal education and how it can be paired with ACE screenings in clinical settings. Universal education offers an opportunity for providers to share information about ACEs, resilience building strategies, resources that might already exist in the community, to all patients, whether or not patients disclose their experiences of violence or their experiences with ACEs or not. You may be familiar with the safety cards that are, there's pictures of them on the slide that you're looking at, that can be used to provide this education to patients. We have one that's specifically related to ACEs called Connected Parents, Connected Kids, or in Spanish, Padres Conectados, Hijos Conectados. And you can order them from our website, and I'll drop the link in the chat in a minute. Before clinicians introduce the card to patients, it's important to really normalize this activity and these conversations. There's a sample script on the slide that shares just an example of how that conversation can go. We've started giving this card to all our patients so they know how to get help for themselves or so they can help others. And the card can be opened, and inside the card, which I'll show an example of in a minute, there's a bunch of different resources and messages around ACEs, the impact on health, and ways to respond to ACEs. The universal education was developed using this acronym called CUES, which is a way to remember the different steps to go through when providing this universal education to patients. The C in CUES stands for confidentiality, which means that it's really important to review the limits of confidentiality in your healthcare setting in order to increase the opportunity for safety and privacy for patients before these conversations are had. The UE in CUES stands for Universal Education and Empowerment. Normalizing conversations about ACEs and other stressors as health issues that your patients can discuss with you is really important. And then you're giving folks information about places they can go for support, whether they disclose to you or not that this is something that they're experiencing. And then third, they can also use the card and take it and share it with friends and family as a way to use the power of community to share additional information about ways that we can all take care of our health and address ACEs in the community. And then finally, the S is for support, which is so important that, and a big part of our project and Project Nessus and our other work to address domestic violence, so important to understand the community resources that already exist in the community, and to be able to know where to send someone when they do share experiences related to ACEs, and even pick up the phone and be able to call that community partner to send that person there, can be a really critical part of an ACEs response. So how is ACEs different from tradition? How is it's okay. How is ACEs different from traditional screening? Or how's CUES, I'm sorry, different from traditional screening? CUES as an intervention focuses on this idea of prevention and sharing information to all patients, regardless of whether or not they disclose. Patients are also encouraged to share those resources with their friends and family. And then advocates or those community-based supports are key partners in the ACEs response as well. So like I mentioned, inside the card, there's anywhere from 8 to 10 panels, and they all have a different message and important information in them. This is a panel that's an example from the card related to ACEs. It talks about impact of ACEs on health, and you can use this, you can share this panel with a sample script, put it in, a clinician might put it in their own words. Here it says, the stress of hard childhoods we know can affect our health, physical health, emotional health, substance use, but that isn't the end of the story. We know that these issues can be turned around with health, with support and help. Kind of bringing into the center this idea about strategies that we can all use to address the impacts of ACEs on our health. Another panel on the card talks about how connecting others to help related to the experience, the impacts that they are experiencing as a result of ACEs can also make a difference. We often see this being something that people really respond to. They want to be able to help others and bring resources to their community. The sample script here says, one of the ways we see communities and families thrive is when we help one another. Sharing this tool might really help someone who is feeling alone or overwhelmed. Anytime someone can make it personal, like notice that someone else could use a little help, it can make a difference. So those are just two examples of panels on that particular card. So the CUES framework can be even coupled with ACE screening at clinics where clinicians are using the ACE screening tool. Universal education about ACEs and toxic stress mitigation strategies can set that table for ACE screening. And like I said, it can support families regardless of whether or not they disclose experiences of ACEs. And it normalizes this conversation having related to the impacts of these experiences on health and can help build rapport and trust. And just lastly, doing this work with our community partners through Project Nessus, I think we're learning a lot about how important it is to build these partnerships with community-based organizations, especially with organizations where their members, their leaders share the lived experiences and values of the community. We've built through that project a bunch of tools related to resilience that recognize and acknowledge the strengths and values and lived experience of the community as tools to prevent and address ACEs and to lift up the response that already exists in so many communities related to ACEs. And then we know that it's really important to build patient education and to provide patient education around ACEs. We're doing that with our community partners, but also around building trust between providers and patients. And then finally, just that community-based organizations, folks own networks within the community, community resources that might already exist, and healthcare providers can all help to address the impact of ACEs. And when that happens together, it can be really powerful in a coordinated way. So thanks so much, and I'll pass it on to my colleagues.
Thank you so much, Elena. And now I'm going to hand it over to Naomi Shapiro and just give you.
I'm here. I'm
Yes.
unmuted. Thank you
There
so
you are.
much. Yes. All right. So my name is Naomi Shapiro. I'm a pediatric nurse practitioner, and I taught in UCSF, University of California, San Francisco, in the School of Nursing and the Pediatric Nurse Practitioner program for many years. And I retired more or less. My family thinks less than more in 2019. And I just wanted to say I'm reporting primarily on research, a little bit on practice that was funded through the ACEs Aware program in California. And I want to really thank my co-investigators, Claire Brindis and Samira Salaman, and our research associate, Sophia Devaro. And I have no other disclosures. Going to the next slide. I come from an immigrant family myself, and my background in practice is as a nurse and nurse practitioner working primarily with immigrant families. I think I've worked with immigrant families throughout my career. I was a nurse practitioner for a long time at various teen clinics because the population nearest to my heart are teenagers. So I worked at adolescent clinics and school-based health centers, primarily funded by La Clínica de la Raza in the San Francisco Bay Area. So La Clínica has clinics in 3 counties in the San Francisco Bay Area and 9 school-based health centers. And I currently volunteer as an examiner and evaluator at the UCSF Pediatric Human Rights Clinic, doing for folks, teenagers and young adults who are applying for asylum. And I've done some research on family separation and strategies for reunification, safety and effectiveness of school-based group interventions with Central American unaccompanied immigrant youth, and then more recently, looking at the feasibility and acceptability of screening both adolescents in general and immigrant adolescents for ACE.
Naomi, this is Pam.
Yes.
If we can just slow down just a little bit for the interpreters. Thank you.
Yes, I apologize. I come from New York. I grew up speaking really fast, and it's been hard to slow down. So I'll do my best. Thank you. So looking at adolescents and immigrant youth in particular, how do ACEs affect these populations? Many immigrants, including adolescents, are arriving in the US who fled violence and experienced traumatic effects during immigration, and then, of course, ongoing discrimination and fear of deportation once here. They may be in the US without a parenting adult or reuniting with a parent after lengthy separations. They may lack any advocates, economic or legal resources. And then they confront here in the United States structural racism, immigrant discrimination, and a lack of familiarity with US institutions, all of which can increase toxic stress. Going to the next slide. So the reason we focused on screening adolescents and immigrant youth for ACEs is that there was really minimal research when we started about the acceptability of screening for ACEs with teenagers. There was limited research about screening for ACEs in immigrant families, and available trainings on ACE screening didn't address the developmental and confidentiality issues of adolescents and emerging adults. So our practice papers aimed to provide concrete insights and suggestions for improving care delivery from healthcare providers, and also suggestions from adolescents and immigrant youth. So we saw a number of barriers to screening teenagers for ACEs. One was a lack of trust. Now, a lot of the early pilots on screening for ACEs started in prenatal clinics and started in early childhood clinics. So in those clinics, pregnant adults are seen frequently during the course of their pregnancy, And, you know, children could be seen up to 20 times in the first 2 years of life. So that's a lot of time for a pregnant person and a parenting adult to develop a relationship with their provider and develop some trust. But teenagers are pretty healthy physically, and they are often seen only maybe every year to every 2 years by their primary care provider, unless they do have some health conditions. So there's less of a chance to develop that relationship of trust. And also, when adolescents are, say, meeting a new provider or being seen without their parent, maybe for the first time, they actually worry a lot about the impact of screening, the ACEs screening on that relationship. If I say that all these bad things have happened to me or my family, you know, is that provider going to think less of me? So they actually really worry about how they're developing that relationship with a healthcare provider. There's a lack of time. If you look at the, you know, the American Academy of Pediatrics, Bright Futures has recommended screenings for every age group, and there are many psychosocial screenings that are recommended for adolescents at this one visit they might be having every year or every 2 years. So things like drug and alcohol use, psychosocial, maybe depression, suicide ideation. So adding an ACEs screen on top of that long list of screens makes it a little bit more difficult logistically for everybody to do that. And the teens may actually, by the time they get to the ACEs screen, may kind of look at it and think, you know, what's going on here, and may or may not check off just because of lack of time. And then there are confidentiality concerns. A lot of the clinics who see young people, and especially immigrant youth, are safety net clinics that are very busy and very crowded and don't have a lot of space. And the screening questionnaires are often filled out in the waiting room with parents looking on. Teens, you know, so that's going to affect how they answer the screening questionnaire. Teens want to know who will see those results, what will parents know, and will past traumas stay on their electronic record forever? A lot of teens feel like even if something really terrible happened to them in childhood, if they feel that they've healed and moved on, they don't necessarily want everybody who meets them as a teenager or young adult to know all about this history immediately. And it turns out that parents have their own confidentiality concerns. Sometimes some clinics screen both parents and teenagers for ACEs, and the parents may feel that there were some really traumatic things that happened early in the child's life within the family that the parent may not want to disclose. Right. So that's the barrier. Those are the barriers for screening adolescents in general. And here are some barriers in additional for screening immigrant adolescents. They worry about the impact of ACE disclosure on immigrant status and the status of their parents. As Elena pointed out earlier, you know, one of the main fears of immigrant families is the fear of deportation of some or all of their family members. There can be cultural and language barriers to developing comfort in discussing difficult issues with healthcare providers that don't exist for teenagers who have grown up speaking English, you know, as their native language from birth, have grown up from birth in the US. There can be mistrust of interpreters, especially in small linguistic communities. I practiced in Oakland and other parts of Alameda County, and we had a large mom population and increasing during the last 10 years or so. And when we first started seeing a lot of folks who spoke different Mayan languages in our clinics, we thought that, for example, there might be one mom speaking community, but it turned out that a lot of folks who arrived here were divided by the village they came from, say in Guatemala, were divided by religion, were divided by other kinds of things, so that an interpreter walking in might be well known to them or their family, and they might or might not trust that interpreter. And so I think that happens a lot in very small linguistic communities. In terms of time, if you have had interrupted schooling, even in your native language, you may have low literacy, not only in English, but also in your native language. And so it takes more time to fill out the paperwork, and that's a higher burden on medical assistants who may speak your same language or come from your culture to actually help with all of those screenings. And then in terms of adolescent confidentiality, those concepts and the boundaries between what teens keep secret from their parents and not and vary a lot legally and culturally, and it may be very difficult to explain that to families. So in terms of best practices we came up for recommendations are, for one thing, it was really important while screening for ACE to screen also for social determinants of health. And the Pearl screener in California, I'll give a link to that at the end of the slides. The Pearl screener has a section on social determinants of health, including community issues. But not every screener for ACE does that. And there's an unfamiliarity with daily living needs and resources that may be a really prominent current stressor. So we talked to some folks when we're doing our research who work primarily in refugee clinics, and they were saying that they sometimes would assume that the person was really traumatized and stressed out because of what had happened to them in their home country. And it turned out that in the moment, what was the most stressful was figuring out how to get the electricity on, how to get around the new city, all those kind of, how to get their kids enrolled in school. So all of those things that are like daily living that are really important to address before people feel like they can actually even go to past traumas. And then acknowledging that the immigrant teen and family have worries about the impact of disclosure on immigration status and talking to them about whether this might or might not have an effect. Next slide. And this is kind of in line with what Elena was saying in the first presentation, that we really found that the primary benefit of screening for ACE was not the score, was not the number that people would disclose, but really the ability to open up a conversation about trauma. And that actually for many immigrants and refugees and those who are applying for asylum, they have already told their trauma stories multiple times. And so maybe that's not the first thing we address with somebody who's new to our clinic and setting, that the timing and context is really important, that it's not just checking a box, and that the conversation and the universal education about resources was actually more important than the disclosure that happened. And this came from both providers, and also teens really said to us, I might not fill that out completely, is what they said. And I know a lot of people wouldn't fill it out completely, but I still might need to get some information. And then really thinking about how to be culturally and linguistically responsive, that screening takes more time. Thinking about language literacy and historical trauma, and then really preparing parents around confidentiality, maybe not having those separate conversations immediately with the adolescents, explaining the limits of confidentiality to parents and teens, really giving a lot of preparation. So I've just giving you some links to the technical reports we wrote up for screening both adolescents in general and immigrant adolescents, and then a link to the Pearl screener. And then just, there's some other references that you may get in your packet later. Thank you very much.
Thank you so much, Naomi. I'm going to go ahead and now hand it over to Cornell.
Sorry, it took a minute for my screen to come on. Hopefully everyone is having a wonderful day today. My name is Cornell Jenkins, the Vice President of Programs, Impact, and Evaluation at the California Alliance of Child and Family Services in the Catalyst Center. A little bit about my background. This field overall, child and behavioral health, really impacted my family. My mother was a foster youth in and out of the system from age 5 to 16, had me at 19, and we grew up together. And that's kind of where the stereotypical story stops. I had my own challenges as a youth, and my mother, despite not having any foundational support to really guide her and prepare her for life, was able to keep me on the straight and narrow despite my best efforts to do otherwise. Got me all the way through school. I practiced law for about 5 years before joining this organization, but was always focused on uplifting the community. When I saw this opportunity, I jumped at it. And so a little bit about the organization, our vision: all children, youth, and families thrive in loving, healthy, safe communities. And our mission is to promote the health and well-being and safety of children, youth and families in California as a collective voice, impacting policy, best practices to strengthen the systems that serve them. Why the Alliance in Catalyst? For the very purposes that we have on this slide. We have the opportunity to engage with folks on different levels. So we're talking about folks in practice and implementation, our provider population, the youth and families that our providers serve. The most important aspect of this, the opportunity to evaluate what's happening on the ground, what's happening with legislation, and to bring youth and families into that. A lot of times research can be fairly gate kept, meaning that the questions that we're asking seem important to us, but are they the questions that we should be asking based on the needs of the youth and families? Just a really quick recap. So our California Alliance at the far left, that's our policy and advocacy arm. We have 160 members all throughout the state of California who participate in various forms of child and family services, residential care, wraparound services, outpatient, school-based mental health, you name it. If it has to do with children and families, our members typically are engaged in those fields. The Catalyst Center is our training and technical assistance arm. That's where we do a lot of our youth and family engagement through and use that as a vehicle to really address the broader system, not just our members. And then recently, we just started Full Circle Health Network, which is a health network that was created to ensure that smaller organizations, large organizations as well, but especially smaller organizations, have more opportunity to contract with some of the managed care plans. That way, as the state moves more and more towards that form of operating where they're engaging with managed care plans, our smaller organizations don't get lost in the shuffle. Really quick, I won't go through everything on the slide, but this is some of the current initiatives impacting children and youth. And so while ACEs is a big part of this, it's a piece of the puzzle. There are so many different initiatives happening, and it's hard to make sense of this sometimes. And so through our training platform, we ensure that providers have opportunities to engage in trainings and lessons that help them improve their practice, but also help them maximize the funding that they can receive through any of these various initiatives. Meeting the moment. Over the last decade, we've seen the greatest system change in child welfare in California. And the most significant reform being Medicaid in California through CalAIM, which is a way of trying to reshape the way we pay for services, restructuring how counties and providers get that funding, and allowing new services to be accessed through health plans. And we've also seen the largest one-time combined investment to address supports for children and families. Now, just because there's a lot of money there doesn't mean that what is being done with that money is efficient, effective, and impactful. And that's where we come in as far as trying to leverage the voices of our members, leverage the voices of the youth and families that we're hearing from to ensure that the state legislators and the counties are designing their modalities in a way that is going to give youth and families what they need. Just another quick slide here. I'll kind of breeze through this and we'll be able to share this information. But these are the areas that we focus on: policy, practice, system supports and change, and members, which is really a combination with the practice, but as a member, you have more access to more in-depth technical assistance. And I'll kind of breeze through this as well. A lot of my colleagues before me did a great job of talking through some of this. And so these slides will be here for you to review if you want to take a deeper look. But this just talks about the toxic stress and the underlying biological mechanisms of ACEs and how that early life adversity without proper protective factors can lead to the toxic stress that impacts your neural operations, your immune system, and your endocrine system. Just another quote here: a consensus of scientific evidence demonstrates that high doses of cumulative adversity experienced on critical and sensitive periods of early life development without buffering, safe protection, stable and nurturing relationships can lead to long-term disruptions of brain development, immune and hormonal systems, and genetic regulatory mechanisms. condition known as the toxic stress response. Here's a list. 9 of the 10 leading causes of death in the US, and ACEs has been shown to dramatically increase the risk for each of these. As our colleague mentioned earlier, the social conditions that increase the risk of ACEs and toxic stress are prevalent. And so while all populations are impacted by ACEs and potentially toxic stress, there are some communities that have a harder time with ACEs and are more likely to have more accounts of ACEs, leading to increased chances of a lot of the health risks that we spoke to earlier. So I'll just skip past that. This here is just a wonderful graphic that I think was put together by the Bay Area Regional Health Inequities Initiative. And as you can see, some of the upstream impacts of social determinants of health, social inequities, institutional inequities, things of that nature. And you get more downstream as you look at the living conditions, risk behaviors, disease and injury, and ultimately mortality. Typically, our health field, behavioral health and medical, has been focused on some of the downstream impacts and trying to address ACEs and health in that way, while we're moving more and more towards, not quickly enough, but getting there, towards focusing on some of the upstream impacts and upstream factors when it comes to behavioral health, mental health, and physical health. Some of the community risk factors. On the top, you see the typical ACEs that we have listed, but below that, there's more that wasn't necessarily classified as ACEs in that original study. Obviously, not obviously, but that original study was done on a certain demographic. I think it was mainly people who identify as white. And so a lot of the things that impact communities of color and low income communities as well weren't necessarily given the same attention, but those things are just as impactful when we're talking about poverty and discrimination, community disruption, poor housing, violence, and lack of opportunity. So here's a list of the groups that we identify that are disproportionately impacted by populations. I won't go through each of the groups. I have a larger slideshow, so if anyone is interested, my email address is also at the end of this, so I'd be happy to share that. But in that training, we did discuss the economically disadvantaged, LGBTQ plus community, communities of color, immigrant and refugee communities, systems involved youth, and other high-risk groups like commercially sexually exploited children. So here's just a little bit of stats to kind of ground us as far as how impactful ACEs are on the immigrant refugee community and also on our overall society. I believe in 2018, 13.7% of our population consisted of immigrants, and we are a country of immigrants. That's how just about everybody here, unless you're of Native American descent or an indigenous population, got to this country. And so to ignore the impact that ACEs and other shortcomings of our health system have on the immigrant population and the refugee population is to do a huge disservice to our overall population. And so some of the risk factors and challenges when engaging with immigrant and refugee communities, obviously there's the language barrier at times and the toxic stress due to fear of immigration status and deportation, lack of stable housing, healthcare, and other rights, and fear of ICE raids in the workplace or at home. And number 3, which is really communities of color overall, the lack of trust in law enforcement when reporting domestic violence or other crimes has a huge impact. When you feel that you're in danger and the folks that are supposed to protect you from the danger only pose more danger, you're obviously less likely to seek that help. I also talked about systems involved youth here, because again, this is kind of where our wheelhouse is. And as we can see, the great majority of young people in foster care have experienced trauma in some form as a result of maltreatment, psychological or physical abuse, neglect, and foster care placement. And I want to emphasize that last item, that foster care placement. The systems that are meant to protect and were supposedly designed to uplift youth and families who need the most help tend to be some of the most traumatizing facilities as well. And no, that's not all fault to our providers who are doing the most they can at times. Not every provider is, but for the most part, doing the most they can with the resources that we have is really on our states and counties to make sure that we are giving the proper attention to this population to be able to provide the services that they need to thrive. So overall, trauma-informed practices for working with special populations allow for self-identification. I won't read through all these, just a few. Create inclusive spaces, educate yourself continually, and utilize peer navigator programs. When addressing things like ACEs and talking about sensitive topics where there is a lot of mistrust already built in, it's important to create an environment and build those relationships and have an environment of trust, of collaboration. Part of the conversation, not just a subject of the conversation. Trauma-informed screening and care. So here we have the trauma-informed care approach to the screening process, setting the foundation grounded in trauma-informed principles, an environment that is calm, safe, and empowering, education about the impacts of current and past trauma, and inquiry about and response to recent and past trauma that includes on-site or community-based resources and treatments. Again, this is really about having a conversation, not in the top-down environment where we see a lot of our healthcare facilities kind of operate from, but engaging in dialogue, allowing the parents and the youth, again, to feel like they are a partner in their treatment and really the driver of their treatment. And it's just our job to make sure that they are equipped with the most information that we could possibly equip them with to make informed decisions. The following key principles of trauma-informed care should serve as a guide for all healthcare providers. Establish physical and emotional safety of patients and staff. Making sure that your team is in a good place and a good headspace to have these conversations and to be able to understand the impact that these conversations can have on our clients and on our patients. Specifically, when talking about doctor's office, I don't know about you, but I was raised in the states with state-sponsored insurance, and a lot of the clinics that I visited weren't necessarily warm and fuzzy places to be. Almost like going into a lab, and I'm the lab rat, and so rethinking how we even decorate the waiting rooms, having a separate place where we can do those screenings that is more comfortable and more home-like, to help ease the minds and ease the hearts of the people that we're trying to help. Building trust between providers and patients. As someone mentioned earlier, you go to the doctors every so often. And so making sure to maximize each opportunity to build relationships, get to know them, and the more you build that relationship, the more they're going to open up about. Promote patient-centered, evidence-based care. Ensure provider and patient collaboration. Collaboration is key. Bring a patient into the treatments process and discussing mutually agreed upon goals, as opposed to just attempting to dictate. Even if you think you know what's best, it's not going to be as impactful if you're presenting it in a way that doesn't allow the patient to feel as though they are a driver in that conversation. And provide care that is sensitive to each patient's racial, ethnic, and cultural background and gender identity. Learning, continuous education, and with that, and that may mean something different for someone of the same, two different people of the same demographic, how their identity shows up may impact the conversation a little differently, so always being open to adjusting and adapting. Cross-sector collaboration. So here we have a trauma-informed network of care, which is a group of interdisciplinary health, education, and human services professionals, community members, and organizations that support adults, children, and families by providing access to evidence-based buffering, resources, and supports to help to prevent, treat, and heal the harmful consequences of toxic stress. Now, this is extremely important when we're working with diverse communities because we can't have all the answers. No, not any one of us has the answers or knows everything about each demographic that we're going to encounter. And so it's great to have a diverse team whether that's internal or the network of partners, to be able to fill in the gaps where we may have any shortcomings, fill in the gaps where we may lack understanding, to give ourselves the best opportunity, the best chance to give the youth and families we work with the things that they need. And so some strategies for cross-sector collaboration, documenting ACEs, toxic stressors, and other adversities in electronic health records, implement data sharing practices with those partners and those trusted networks, utilizing technology to help make sure that we can share information that is in an efficient manner and an effective manner in real time. Establishing MOUs, memorandums of understanding, to understand that when I have this gap that I can't fill, this is the person that I go to. This is the organization that I go to. Having those in place and formalizing your partnerships. Implementing cross-sector case review teams. And one of the biggest things is utilizing navigator programs, bringing in peer navigators to help serve as credible messengers. It's a lot easier for a patient to identify with someone who can speak the same language as them, who looks like them, or has a similar background or understanding of the way system works as them, so that they can have that trusted voice to help guide and build a relationship and act as a bridge between the patient and the clinician. Here are just some examples of different cross-sector partners you could be looking for: community members, government agencies, behavioral health partners, healthcare partners, technology, education, faith-based organizations, and community-based organizations. One, effectively addressing health issues and community requires this collaborative effort of different sectors. A strong network of partners is necessary to develop programs that will address the social determinants of health, especially in the healthcare field. No single individual, organization, or sector can change the course of America's health. I think I breezed by this really quickly. I know a lot of my partners have previously covered some of this. So, yep, I did breeze by. So here's my contact information. Again, we have two organizations, our Alliance and our Catalyst Center. We also have our helpline, which is run through our Catalyst Center, where we can provide technical assistance. So if anyone's having any situation where they need some guidance or assistance on how to connect with a partner, on how to work with a particular youth, you can call that helpline number, shoot an email there. If we don't have the answers, we will find the answers and make sure that we're sending resources along the way. And at our Catalyst Center website, check out our training platform. We have a lot of different trainings working with youth and families in different communities. So thank you very much.
Thank you all. Thank you to our panelists. I have a ton of gratitude for your time, your dedication. We do have a couple questions in the Q&A section. We have 10 minutes, but I think we can get through these two questions. The first question is addressed to Cornell. So Cornell, is there activity around increasing background checks, evaluating foster placement to decrease ACEs for children in the foster system? How do you do this while filling the need for foster placement?
That is a great question. And if I had the entire answer, I'd probably be a very wealthy man. No. So a lot of the background checks for foster families, honestly, I think that's not the biggest issue that we're facing. I think the biggest issue is the way the foster system operates in general. When you're uprooting someone from a family and placing them into another home, that in of itself is a traumatic experience. And then on top of that, if and maybe this is where I'd say maybe a more thorough, I wouldn't call it necessarily a background check, but a vetting of fit for the family and the particular youth, because oftentimes you get into a placement, and if they start to exhibit behaviors that are reasonable, predictable, understandable given the circumstances, it could be the case that the family, even though they knew what was on paper, weren't ready to handle what was going to present in reality. And then when that happens and you have another disrupted placement, and then that youth goes to another place, which deteriorates their trust in the system, deteriorates their trust in the next foster family agency that their foster family home they'll be in, because in their minds, well, I'm just going to be bounced around and moved around. And so that causes issues. one of the biggest things the state is trying to move towards, and we need to create a system to be able to do this, is looking for more kin placements, and trying to allow youth to be with family as much and as often as possible. The challenge with that is, as a resource parent or foster parent, this is almost a career. This is what I signed up to do. This is what I want to do. This is my focus. As a family member, in most cases, I did it myself with my nephew. You don't want to see your family on the streets, and so I said, okay, I'll take them in here, but how they engage and interact with the system is a lot different. They don't, well, a lot of times, kin parents, they don't trust the system themselves. So having people coming through their homes and looking through their stuff and doing all of these things that try to create an environment that even the best of parents don't reasonably have at all times makes it very difficult for us to go down that route. But that is where a focus of the state is. And as the Catalyst Center Alliance are definitely in support of that and figuring out, okay, instead of just slapping the Band-Aid on and saying, oh, yeah, kin family, let's build a system that provides those supports in the first place so that when kin families do step in, they're equipped, they know what's going on, and it's a good experience for all involved. And preventative services as well before we even remove the youth, I think is something that we have been lacking.
Wonderful. Thank you. Thank you so much, Cornell. And I think we have time for just one more question. I'll refer over to my colleague, Alma.
Yes, thank you. So here's a question. How do you ensure that children get continuum of care or establish trust with health providers when children are in an unstable environment, for example, experiencing homeless or foster care? And the second part of the question is, are there certain strategies that health providers can employ when caring for youth and families in those situations, like making sure that they have a positive experience as at their healthcare center and leave with resources to continue care? I know it's two questions in one, but Noami, probably.
Yeah, I can at least start to answer. And I would say that one way is to really focus on a lot of services in schools, school-based health center and other school-based health, because most kids, even in very unstable conditions, are going to school. There are rules in California that kids are supposed to stay in their same school, even if they are put in foster care. And I know that's not always the case, but I think that is one way to be stable. And I would think maybe, I'm not sure if Elena has other thoughts, but just around, I think also just acknowledging for kids that you're aware that they're coming to a new place and to being as compassionate as possible. Elena, do you have anything to add?
No, I think that all sounds good. I think for families too, part of the question asked about ways to make the healthcare center a place that feels positive and a positive experience. And I feel, Cornell in your slides suggests or shared a lot about trauma-informed care. And some of that is, just about training staff at the front desk to about the impacts of trauma in people's lives and how to be that space at the front that is really welcoming and supportive and communicates to folks that this is the place where you should be. We're here for you. Even just that, small things like that, I think can make a big difference. And then, I think all three of us, I think, mentioned something about building trust with providers as being a really important part of this, that these conversations don't all need to happen at one visit. They can happen over several visits, and that can be really important to building trust. And then the third thing I think is really building quality relationships that health centers have with community-based organizations that are really connected to specific populations like homeless youth or foster care families, farm workers, community-based organizations that are based in those communities, from those communities that understand those barriers and challenges and strengths that the community share, and may have offices across multiple places to better serve families that might be moving around.
I'll add one thing, and I love everything you just said, both Yelena and Naomi. And the one word that comes to mind is a non-judgmental place. I can't tell you how many times I've been in the doctor's office. My mom has been in the doctor's office, and even the most well-intending doctors, when they speak to some of the things they're seeing, it's almost like, oh, well, you shouldn't be doing this, or that's bad. Well, probably know that. And they're still doing it anyway, which means there's something underlying, and being shamed and being told and scolded is not the best way to invite and welcome folks in. The situation is what the situation is. So let's figure out a way to get on the same page and figure out and find solutions in partnership, as opposed to being reprimanded, even in the most well-intended way.
Thank you. Thank you very much.
Thank
That
you. Yes, thank you so much to our panelists. Now I'm going to go ahead and hand it over to Martha just to close things out for today. And thank you everyone for attending.
Thank you everyone for joining us as well. Really quickly, later on today, I will be sending you all a follow-up email. The email will contain the PDF versions of the English and Spanish slide decks, the links to the English and Spanish evaluation, and I'm forgetting something, and the links to the English and Spanish video recordings of this presentation. Again, look for that in your inbox later today. And with that, it looks like our time is up. Thank you everyone for joining us. Special thanks to our interpreters. Thank you so much for the work you do. And thank you again, everyone. We'll see you all another day.
Thank you.